Aujourd'hui, l'état de conscience et les mystères du cerveau, eh bien, nous allons en parler. C'est ce dont va nous parler l'oratrice suivante. Monsieur le Président, là aussi, l'intelligence artificielle a permis à la science d'avancer et d'aider les patients et leurs familles.
Yes, of course. Our next speaker is Athena DEMERTZI, co-laureate of AstraZeneca Prize in 2020, and working at the GIGA Consciousness Lab in University of Liège. Dr. Athena DEMERTZI is FNRS Research Associate at the Institute GIGA since 2018. Holding a PhD in medical science in 2012 at Université de Liège, she has graduated as a psychologist from the Aristotle University of Thessaloniki, Greece in 2005, with a subsequent master specialization in cognitive neuroscience and neuropsychology at Maastricht University. In short, her research contributes to the knowledge about the human mind, even when this cannot be communicated overtly. Athena DEMERTZI currently directs the Physiology and Cognition Lab. With her team, they investigate brain-body interaction as a proxy to human sentience in health and disease by means of high and low-tech methodologies. She was recently awarded with the Scientific Award in Patient Care in the Artificial Intelligence IRE 2020 by the AstraZeneca Foundation for a contribution to individualized patient care by means of machine learning applications. She also received the FNRS Mandat d'Impulsion Scientifique for the project Evidencing Sentience in Low Arousal States by Probing Brain-Body Interaction. In the past, she was FNRS postdoctoral research and an INSERM fellow at the Institut du Cerveau de la Moelle Épinière à l'hôpital Pitié-Salpêtrière in Paris. Her PhD was funded by the DISCUS Marie Curie Research Training Network and the Université of Liège. The title of her lecture is Application of Artificial Intelligence to the Study of Consciousness, Neurology, and Neuroimaging. Professor DEMERTZI, it's yours.
Thank you so much for the kind invitation. It's a pleasure to be here today. Hopefully next time we can be in person. Yes, indeed, my background is, for this lecture, will come from the field of neurology, mainly. I've worked in the past, especially with brain-injured patients, where we have a very big problem that they cannot communicate to tell us how they feel, experience the world. And like that, we don't know their wishes for treatment options. So when I talk about disorders of consciousness, these are heavily brain-injured patients for whom we have to infer the cognitive capacities, their mind, from behavior. So in that case, people who find themselves in coma, they are considered unconscious because they cannot evidence it overtly, because even if they are severely stimulated, like even painfully, they will not open up their eyes and communicate. When we have preserved arousal levels, for example, by eyes opening, but patients are not able to communicate, they are supposed to be in a vegetative, unresponsive state. And they still remain and considered unconscious. We have sometimes some of these patients, though, that they can show some type of high-order motor responses, like sometimes they will show non-reflexive movements, like following their image in a mirror, or they would respond to command, let's say a simple command like raise your thumb. And in that case, they're supposed to be minimally responsive in a minimally conscious state. And the problem still remains because we can still not communicate functionally with these patients. So in the absence of communication, how can we know that somebody entertains some subjective experience? How can we quantify their mind? My contribution to that comes from the paradigm of resting state. This is to say that when patients receive MRI scanning, it's very convenient for us because then we can ask the neuroradiologist to record functional data. So for 10-minute acquisition with using functional MRI, we are in possession of big amount of data that now we need to make sense of, like how this kind of functional communication between regions of brain regions can tell us something about the level of consciousness patients. So the resting state, indeed, it's not a condition where we do nothing. When we are even like not engaged in a task, when we stay silent, our mind is very, very busy. So we will entertain different types of thoughts. Our mind will go in the future, in the past. It will have a very rich mental repertoire. So this means that even that we have the evoked changes in the brain entertain less than 5% of the brain's energetic budget, because most of it goes for neural signaling. This means that conscious awareness is energetically inexpensive. But it depends upon a very complex and dynamically organized state of the brain, which achieves at great expense. Talking about networks, I will talk in my lecture mostly about brain networks during resting state. So this means that we will come across the term functional connectivity, which is nothing more than statistical temporal correlations between distant brain regions. So we can see here in the bold signal, which is what is measured mainly by the functional MRI across time, how the time series of the bold signal from different regions, distance regions, show fluctuations in synchrony across time. So in that case, we say that these areas are functionally connected and they comprise a type of network. This is the most famous network in cognitive neuroscience, the default mode network. For those that, you know, it's one of the first ones that came up. But now we know that actually the brain during rest self-organizes in more such systems. Systems that they show long-range connectivity. So we have here the default mode network. Here we have frontoparietal areas from the left and the right. We have networks like that they support the detection of Cialin's important stimuli in the environment, like the detection of pain. And we also have sensory networks like motor regions, auditory areas. We see how the visual system is really decomposed in sub-networks as it's very, very complex, as well as the cerebellum. By using this systems level approach, how can we use this one to separate single patients? Actually, that was a big problem because, as we said, like sometimes patients they show different phenotypes, and they can we can sometimes confuse a patient that is in a low level state with a higher level state with lower, because patients can suffer from aphasia, or they cannot like they don't understand the command, so we cannot estimate high brain function. In that case, we use machine learning. As Ivan said before, he showed several methods. And here we show how we use supervised machine learning. And very, very simple terms, it's like this is a method like when we have raw data of different type. We use a supervisor which will label this data as this or other category, right? And then the algorithm will train to separate those labels. So when we have a new evidence, new observations, we give it to the algorithm, and it will most probably give us an answer that goes closer to this class. So we use this supervised machine learning in order to try separate patients in different classes, consciousness classes. This is a very, very, one of our first studies that we did where we decomposed the brain networks using independent component analysis, and we first identified them in networks using templates. So this is a template matching. These are the templates of each network and how it fits the decomposition that we use using independent component analysis. Then we assign each network to a map, and we go for another step where we try to separate those networks that they show neuronal activity or non-neuronal activity based on some characteristics of the spatial and temporal characteristics of the independent components. And this was the first use of artificial intelligence to that matter. What we found is that this neuronality feature, when we use as a way to separate, it was informative because we found that the neuronal components, they were quite preserved in healthy people, and there were less and less, fewer of them as we move to minimally conscious, unresponsive, and comatose state patients. When though we used this feature as a way to separate patient groups, we failed in that the performance was very, very low. And the performance we achieved, the highest performance we achieved was to separate healthy from patients, from healthy controls from patients. So this gave us an accuracy of almost 85%. Which means that we're still left with the question, how can we use this systems level approach? So easy, so simple in nature to separate single patients. We proposed to increase our statistical power by including more patients. That was a collaborative work with the MIT. So in that case, we used as many patients as we could, and instead of using independent component analysis, we used a hypothesis-driven approach. But this means we use different seeds in the brain that represent each network, as we can see here. So what we did is we tried to sort which network could separate accurately patients from minimally conscious state patients from vegetative, and we found it was a high accuracy for the so-called auditory network. Auditory network, when I say it just comes with an name due to the literature, but if we see it closely, it encompasses areas in the temporal and the occipital cortex that, if we are to identify it sensorially, this is regions that support audition and vision. And this connectivity between these cross-modalities, we found that it was very powerful in identifying and separating new patients that we have not seen before into these two classes. So we had the chance to collaborate also with colleagues from Austria, Cornell in the US, and Canada, that they shared some data with us. So we see here the training set. So this is the set that the algorithm was trained on in circles, and the test set, the new data here in asterisks. And we decomposed the feature space into 3 dimensions, we got information from the occipital cortex and the right and the left auditory cortices. So based on this, we try to find the best separation. This is a hyperplane here of how these two classes can be best separated. And we found that out of the 22 new patients, the algorithm was able to classify 20, which means that this type of cross-modal interactions, a multisensory integration, is significant to support and separate conscious individuals. Using another type of machine learning, the question was how beyond specific hypothesis, are there brain configurations that can support consciousness more than others? And in that case, we went to see how the connectivity dynamics can help us to this matter. So this means like here we can see this is the functional connectome and how it changes across time. So here every line, every column is a brain region. And this is a correlation matrix from negative to positive correlations. And we see how variant these cross-talking between regions it can be in conscious conditions. So in that case, machine learning was used to identify patterns, structures across the brain data. And this is just an illustration, very simple illustration of how it works. We give a lot of data to the algorithm, and then we ask to find the best pattern based on some number of clustering, for example, here 3. And by an iterative process, it tries to find new means of the data that they are less distant from one another. By doing that, we found that actually across time, our brains can show different configurations. They can show configurations that are very, very complex. As we see here, each network across this network, it can it's characterized by positive and negative connections at the shore, at the neighboring nodes, but also distant, which comes in sharp contrast with another pattern where regions really don't communicate with one another. So we can see here that the coherence between the regions is around 0. And then we have intermediate patterns that one is driven by especially the occipital connectivity, and another one that shows all-to-all, like positive connectivity. All areas talk to each other in the same way. We then went to quantify how much the occurrence rate of each pattern in different groups. So we see here the healthy people, minimally conscious state in unresponsive patients, and how pattern 1, this complex pattern, has more chances to appear in healthy situations, and how this very, very simple pattern has more chances to appear in situations where consciousness is feeble. We had also a great chance to collaborate with the Necker Child's Hospital in Paris. And they had resting state data, and they asked us to try and make sense of what they need for hemispherotomy patients. So we had the chance to check the data of 2 patients, pediatric patients. We see here that they had right hemispherotomy, so it was complete hemispherotomy, including also the thalamus. And we can see how the interhemispheric connectivity, like how correlations between hemispheres look in healthy children, as we see here, and how this connectivity in patients would be very, very low. This is the patient MA and JJ. The 2 hemispheres will not communicate as effectively as in healthy people. Interestingly, when we looked how networks look like in these patients, we see again the 6th one, DMN, frontoparietal, salience, auditory, motor, and visual. And we can see how these are coming now lateralized. So on the isolated right hemisphere, now the connectivity is absent, so there is no interhemispheric transfer. Although on the other side, the networks look quite preserved. And by the way, these patients are healthy in the set, functional. They go to school, they acquire new language, they are fully integrated socially. And the question is like how they can do that with one hemisphere, and importantly, what happens to the isolated hemisphere? This was actually, it was a pertaining question, because in simple terms, it's like, can we entertain some type of consciousness in an isolated brain tissue that we don't use for functional reasons? So what we did, we used the classifier we identified in patients, as I showed you before, in minimally conscious and unresponsive. And now we used, we tested the brain of the patient MA, and this was because this patient was closer to the age group of the disorders of consciousness patients. So we see on this side the classification toward unresponsive unconscious state, on this side the classification toward minimally conscious and higher consciousness. And the connectivity between the temporal and the occipital cluster of patient MA was closer to the class of unresponsive patients for the right hemisphere, the isolated, whereas for the preserved left hemisphere was most closely among the class of the minimally conscious patients. Just to conclude, we used the artificial intelligence machine learning methods in consciousness research, neurology, and neuroimaging. And by this way, we managed to unravel the complexity of consciousness states. We had the chance to find single patient separation features, for that matter. And in that case, we also had the opportunity to illuminate relationships between structural and functional connectivity. And now the next challenge for us is how we can bridge different levels. So we have going from the computational level that we operate so far to the neural microcircuitry, meaning like how the networks emerge, how they are regulated at the neuronal level. I know it sounds reductionistic, but at the same time, I think crossing these different levels, we can have more insights about how the brain works, not only in disease, but also in healthy situations to inform about typical conscious states. And that would be it. Thank you so much for the invitation. I'm looking forward to discussions, and there we are.
Yes. Athena, thank you so much. And there is a first question from Professor Jean-Luc Baliban. You're on mute. Yes.
Yes, thank you, Vanessa. Athena, this is a really very nice illustration. I'm just intrigued by the very last sentence that you said, and I'd be very interested to learn a little bit more how you want to approach this neuronal circuitry. Would you go to reductionist models in that case, which, and how would you apply some of your methods to really identify this at the neuronal level?
So at the moment, we're trying to understand how. I'm sorry, I have some lag in the image. Can you hear me properly?
Yes, we can, yes.
Okay. So at the moment, we're trying to understand how the large-scale networks emerge in the first place, trying to understand the let's say the biological underpinnings of the Bolt signal in the first case, and how this formation can work into understanding how the large-scale brain networks appear. So we go towards the hypothesis that it has to do a lot with neuronal inhibition as a biological mechanism. And with colleagues from the computational neuroscience modeling community, we're thinking that still it's a hypothesis, right? By how we can use these biological mechanisms in simulation models, trying to figure out how these can configure networks at the computational level. So at the moment, it's quite, we need to work with simulations. I hope one day we can be more invasive in order to help patients, maybe with animal models at the beginning, later with more invasive ways. But this is one way that we're thinking of doing so.
Thank you. And obviously you're focusing your research on states of consciousness, but one could even think about applying some of your approaches to states of dementia. And I'm sure that some people at your institute may already be applying some of your analysis analytic methods to dementia and other states of altered.
Absolutely. Actually, I'm interested in different conditions where the phenomenology of conscious experience can change. Dementia can be one such condition. We have, for example, trying to quantify the how can you say, the wandering mind, how people would say that I'm thinking of this and that in healthy aging. So we have this hypothesis about mind blanking. You know, like we have sometimes the impression that you don't think of something, contentless thinking, contentless thought. And we think that this is very well supported by a specific brain configuration that we are now having good impression of what happens, but I'm not going to disclose anything because it's in preparation. I want to be sure before saying anything. But indeed, aging, dementia, situations that lead to distorted phenomenology at some point interest me deeply. And machine learning especially has helped me a lot to that matter.
Thank you.
Athena, the next question will come from Professor Benoît Mac.
Yes, your favorite modality seems to be the functional MRI, when you observe both signals. In my teams, there are some people working on the white matter by using diffusion-weighted MRI and looking to tensor and to microstructures and so forth. When you are speaking about connectivity, do you see some way to combine the two modalities and to search for signals showing the connectivity that you observe by the functional imaging? What are the prospects to combine fMRI with diffusion-weighted MRI?
Absolutely. In the Sense Advances paper where we show the different brain configurations, we actually combined, we checked the correlation between the functional connectome and the structural connectome, and we found that the highest correlation between the two was happening in the state where the areas don't talk effectively with one another. So it was mainly the underlying anatomy that was driving the connectivity. And now with my PhD trainee, we're trying more sophisticated methods about, for example, the alignment between structural and functional connectomes and the deviation from one another, how this can inform mental flexibility, for example, or disease categories. But indeed, one and the other can give more information. It's kind of finding, like constraining the whole brain's functional connectome into more meaningful ways. The anatomy can be one type of information, although more lately the genome, the human genome, can also be very, very good at that. So yeah, you're absolutely right when we need to combine the different modalities as well.
Efkaristopoli.
Professor Casimir.
Yes, thank you very much for your very interesting lecture. My question is a question of clinician. Do you have assessed the sensitivity and specificity of these new complex methods of neurological computational analysis to move wider in routine clinical use?
Officially not yet. Unofficially, we've been testing the classifier, at least when I was in La Pitié, very intensively. And when I came back, we're trying to use it in every clinical case we're having, just to have information about how it generalizes. At some point, I think, yeah, we need to go more applied and channel it in a more applied way and help further. I have not done that yet. I really wish I will. I'm thinking how, like as a young lab, I have so many things, and this is one of the bucket list that I have to check also. But I promise I will do it. I would love to do it, indeed.
Thank you very much.
Athena, your bucket list is so long that I think you will keep working till 100 years, at least.
If I have the same skin, with pleasure.
Yes, I wish you to have a long life.
Thank you.
And thank you so much for this conference.